Thank you. Our next speaker is Thomas Murray, who is the President Emeritus of the Hastings Center and Chen Su Lan Centennial Professor in Medical Ethics, Yang Lu Sin Lin School of Medicine, National University of Singapore. Thank you.
Thanks very much. Good morning. I see many old friends here and say hello to them, but also people that I haven't met before. Pleased to be honored actually to be invited to speak. I've been at this a very long time, not this issue, but this field and issues about parents and children, long enough to have a feeling that not all questions are created equal. That is, some questions lead us, I think, into blind alleys, whereas others open things up. They're fruitful, they are richly intertwined with other questions that we can draw important moral insights from. So I'm going to focus on trying to ask the right questions and suggesting that at least some of the questions, at least as initially framed for this panel, might not be the most useful. So first, the framing. Why would we want to do something like mitochondrial replacement therapy? And sometimes you have to ask the obvious question first. And I take it's because that there is a deep desire on the part of parents, such as Heather, to have and raise healthy, biologically related children. Now, what morally legitimate interests are served by MRT? And what makes those particular interests important and compelling to us? And are there alternative ways to satisfy those interests that would serve them as well or nearly as well? On the other side of the ledger, what are the moral considerations that would lead us to exercise caution in the use of MRT? And are those reasons for caution powerful enough to outweigh whatever interests are would not be served if we were not to permit it? Now, prospective parents' interest in having a genetically related child, a child who would be spared from the ravages of a known heritable disease, has been judged, I think, broadly by many countries, certainly in the United States, as strong enough to justify a very wide array of assisted reproductive technologies, of which MRT would be a new form. Now, there are, in fact, other good and honorable ways of matching children in need of parents with adults able and willing to be parents, and these should be wholeheartedly supported. Heather mentioned adoption and egg donation. But the desire for genetic connection, we just have to acknowledge, is deep and widespread, and it's respected in the wide range of other ARTs, and so I see no compelling reason not to respect it in the case of MRT as well. So a useful question next step would be, how is MRT similar to or different from other assisted reproductive technologies? So the closest analogs, I think, would be ARTs that aim to create healthy children. That is, not just to have a biologically related children, but to have such a child in the face of the threat of a very serious disease. Furthermore, it's an intervention that happens very early, prior even to implantation. PGD seems to me a kind of close analogy. If there are others, I look forward to hearing about them. Okay, what about risks? People have mentioned, well, the committee itself has mentioned things about identity, parenthood, and ancestry, and possible confusion there. I think that the background of that is it presupposes a much neater world than we actually live in. There's a lot of confusion about ancestry. Children in need of rearing and parents who desire to raise those children come together in a wide variety of ways, not just adoption. Formal adoption. There are a lot of informal ways in which that happens as well. And we don't have compelling evidence that this results in horrible identity confusion. I mean, some adopted children, when they approach adolescence and are weathering the storms of adolescence, decide that one of the reasons they're unhappy is because they were adopted. That may or may not be true, but many of them come through that very, very well. I see no compelling reason to think that children under these circumstances would have any greater difficulties. For all the other main questions, health risks, how would this differ from other ARTs? And there's a lot of scientific questions to be answered. Risk to the mothers who would bear the children, risk to the women who would provide the eggs that would have to be used in the procedure. Again, how would that be different from other ARTs? There was one feature here that may make it a bit different, and that is if haplotype matching is seen to be important, then there would be pressure on close relatives of the mother to become the egg source. But that may happen in other ARTs as well, for all I know, so I don't know how different that is. Equity, access, and the other issues mentioned, again, how different will that be from other assisted reproductive technologies? Not to say that it's not a problem, but just let's be clear, let's anchor it in a discussion about other issues that we think are reasonably well settled. There are some questions that I didn't see raised, but I think are quite important. They were raised by Nuffield and the HFEA. Should we regard all early efforts at mitochondrial replacement therapy to be part of clinical trials? This is where, it's not a strict requirement, but in pediatric cancer, trying to enroll all children with pediatric cancers in clinical trials has been hugely valuable in the advancement of treatment for children with those cancers. Should we require an effort to provide long-term follow-up of the children? Now, you need, obviously, the parents okay with that, and you need the children at some point, when they're capable, to consent to that. But wouldn't that would be a very desirable thing. Should we require clinics to have donor registries and follow-up of donors with the possibility of notification should the donors later on develop a mitochondrial disease or other genetic disease? And should we create and follow policies that will specify what children and parents can know as donors and what donors can know about the children? Now, less helpful questions. Consent, first of all, the framing of the issue of research as the children's consent. Now, consent draws its moral force from the sort of standard case, a fully competent, independent, free adult who says, yes, you can do this to me in the name of science. Efforts to hammer consent into a shape that actually works for children have, I think, utterly failed. I tried to document that in my book, The Worth of a Child. Two giants of early bioethics, Paul Ramsey and Dick McCormick, made valiant efforts at it. I think both were abysmal failures. Ramsey ended up with an incredibly strict concept of consent for children that would have eliminated virtually all pediatric research or even social research with children. And Dick McCormick, both of these were friends of mine. Dick McCormick had this contorted view of how children really would consent because they should consent, which bears no relationship to any children of I have any history with, including my own very much. So I would reframe the question. I would want to know what justifies research on children, what legitimate moral considerations, how do we specify the limits of that research, and what are the boundaries of parental discretion and consent? Because surely parents or other responsible adults will be the bulwarks of protection for their children. Now, let me take the next step, go downstream a bit. This crosses the germline barrier in a way. It does that. That barrier has been a comforting principle for bioethics to think about gene transfer research for a very long time, really since pretty much the first discussions of it. MRT breaks it, although in the gentlest way possible. We're talking about very serious diseases. We're talking about genes that, if they were not defective, would appear to have little or nothing to do with the traits that matter to most people. We're talking about not touching the genes in the nucleus. And if it is successful, not only would it potentially cure the disease in a child a daughter that would be born, but it would, particularly if it's a daughter, any child, but if it were a daughter, would also potentially cure the disease, spare future children from the same disease. So yes, it crosses the barrier. We need to be honest about that, but this is tiptoeing across rather than assaulting it. Of course, the problem is if you've crossed the barrier, is everything now permitted? And indeed, we're confronting a variety of challenges with ideas about trait selection, genetic screening, or even enhancement of children's traits. This is not a common practice now, but one can hear the conversation is already picking up steam. So here we have to ask, well, what should be permitted? Who has the moral authority to decide when such things happen? And what ought our public policy to be? The problem in the U.S. is we have inconsistent, unsatisfactory, and unhelpful answers to most of those questions. Inconsistent, for example, if you look at my essay in science from last year, with things such as sex selection, you have ACOG giving one answer and ASRM giving another. With genetic screening for traits of potentially late onset diseases, again, you have ASRM giving one answer, you have the American Academy of Pediatrics and the American College of Genetics, Medical Genetics giving a different answer. So you've got inconsistent professional guidelines. I think it's unsatisfactory in that I think the regnant ethical framework in the ART industry just isn't up to the job. It's a very comfortable one because it permits them to have whatever conversations they want to have with their clients and so to do what their clients want. I don't think it's an adequate one. And I trust you will press my dear friend John Robertson when it's his turn to speak about that. And it's unhelpful in that there's been no political will to regulate. Does the fact that it's blinking, what does that mean?
Means you're out
Am I
of time.
over? Am I already
Means
over?
you're finished.
Okay.
Yeah. That means we bring the hook out really soon, Tom.
Okay. So one of the questions you framed is, you didn't call it the non-identity problem, that's what philosophers call it, but is it the same child or is it a different child, and how should we think about that? I fear that may be one of the philosophical blind alleys that some of this conversation's gone behind. And to jump to the end of what I want to say here, I think some commentators assume that this means that this leads to a standard that pretty much anything is permitted that doesn't result in a life that is not worse than no life at all. That is an awfully low moral barrier. I don't like it. So let me suggest an alternative way of framing it. I described it in the book a while ago. So how do we think about our moral obligations to children who are not only not yet born, but not even yet conceived? So imagine that someone discharges into a public reservoir, water supply for a town, a substance that is known to cause mutations in gametes, such that at least some of those gametes might still be capable of, fertilization and leading to the birth of a child, but that child will be not healthy. The child will have serious diseases. As I understand the way the non-identity problem is framed by philosophers, it's hard to explain how that person had any moral obligation to those creatures, because, they didn't exist, and they wouldn't have been, they're not worse off than this hypothetical creature with whom we have no one to compare. But I want to say, well, wouldn't we hold that individual morally accountable for having done this? Wouldn't the child, any children so born, have the right to say, "You've harmed me, and you have a you've violated any moral obligation towards me"? And if we can have that conversation, let me suggest we just try to do it through that framework rather than through the non-identity problem. Thank you very much.